Good evening, dear Foxians. It fills my heart with immense joy and gratitude to welcome you all to Gyan Pravah, a special podcast conceptualized under the visionary leadership of none other than Dr. Sunita Tandulwadkar. I am Dr. Sejal Naik, chairperson of Fogsi Endoscopy Committee, and I will be here with you on 8th of every month, meeting, conversing, and learning from legends in our field at Gyan Pravah, Flow of Knowledge, a podcast that promises to enlighten, inspire, and elevate us all. I feel honored to share this platform today with two legendary giants in our field of endoscopy, Dr. Sunita Tandulwadkar, pioneer, expert endoscopist, and Professor Horace, globally renowned endoscopists, especially for endometriosis. I am grateful to have you today, dear madam and sir. This moment is incredibly special to me. I request Dr. Sunita Tandulwadkar, a visionary leader of 4,600 gynecologists across India as President Fogsi, for her welcome address. Dr. Sunita Tandulwadkar is not just a leader, she is a phenomenon, a pioneer in gynecological endoscopy, high-risk obstetric, IVF, oncology, robotics, ovarian rejuvenation, and stem cell therapy. She has placed India on a global map with her relentless pursuit of excellence. As President Foxy, past President of Indian Association of Gynec Endoscopists, President-elect of ISAR, and Founder President of Society of Ovarian Rejuvenation, she has redefined leadership with courage, innovation, and unwavering dedication. The Director of Solo Clinic, Head of the Department, Chief IVF Consultant at Ruby Hall, and co-founder of Alive, a state-of-art stem cell research center. She has made history in India's first stem cell baby in year 2018. Her wisdom, her relentless passion, and her ability to dream beyond boundaries have transformed the landscape of gynecological endoscopy in India and beyond. A prolific author and orator, she is also a great teacher of many, including myself. Her contributions, both academic and clinical, has been recognized in the form of various numerous awards. Few to name are the Bharat Gaurav Puraskar or the Glory of Indian Award and Rashtriya Gaurav Award, etc.
Thank you,
For me, Madam, for me, you are not just a teacher. She is my guiding light who has shaped my journey. She has installed confidence in me and given me a wings to soar. Today, Gyan Pravah stands as a testament of her unwavering commitments to knowledge sharing. She has given us, to all her chairperson, a platform where we could have never imagined a space to learn, to grow and make a difference. I cannot express how honored I feel to be here in this journey, madam. And this extraordinary topic with sir, that is deep dive into the deep infiltrative endometriosis, a master's path to mastery. With heartfelt gratitude and deep respect, without further ado, I now invite my mentor, my teacher, my inspiration, Dr. Sunita Tandulwadkar, to deliver a welcome address.
Thank you so much, Sejal, for such a kind words and a generously used. Professor Roman, thank you so much. I think we, not only at India, but globally, we love to see your endometriosis surgery. With every surgery, you show your dominance on the field. Sejal, I congratulate you for selecting Professor Horace for your first podcast. This organization, sir, is of 46,000 gynecologists across with 286 societies. We are 75 years old organization. I'm fortunate to be a president so later, so that the very well-formed, disciplined, organized organization got ready-made in my hand. The president in academic wing is also assisted by 5 vice presidents and 30 committee chairperson. And we have on an admin block, secretary general, joint secretary general, treasurer, joint treasurer, and joint secretary who work 24/7 to make this organization what it stands today. What is most important is these 30 committee chairpersons are the leaders of Fogsi for tomorrow. And when it came to giving them something different, innovative, the most important thing I thought of 30 committee chairperson, give them 30 days. So if Sejal is coming on 9th, Sejal, you're coming on 9th of?
8th.
So she will be coming on 8th of every month with different faculty. It may be from academic, it may be spiritual, it may be philosopher, it may be just the politician. They can take from India, from abroad, because now we live in a digital world where everyone can be connected and the best of the talent can bring up, the meaning to the podcast. We at India are asking every Foxy members to log on at 8 p.m. with the podcast. They may not see us. They can just do the Bluetooth, put up the Bluetooth and keep on driving and hear my committee chairperson what they are. They may be having a dinner, put the Bluetooth. Your wife may be thinking you are listening to her, but you are listening to my people, my 30 committee chairperson. And every day at 8 p.m., I log in just to show the respect from the Foxy to the faculty, whoever is joining and spending their valuable time. I'm sure, Sejal, today's webinar, or I should say podcast now, today's podcast will be one of the best podcast, and it will be not only on a YouTube, it goes on a Facebook, Instagram, it goes on Spotify. I don't know so many digital platforms, but I see you are very active, sir, on Facebook as well. So you will be definitely crossing your own path, listening to your own podcast someday. Thank you so much for being here, and thank you for being a part of Foxy. Over to you, Sejal. Thank you.
Thank you.
Thank you very much.
So today we are privileged to host a truly exceptional guest, a global authority, the master of endometriosis, and the ultimate guru for endoscopic surgeons in the field of endometriosis, Professor Horace Roman. Professor Roman is a name that resonates across the world of endometriosis surgery. He is pioneer surgeon recognized globally for his expertise in laparoscopic and robotic management of complex and deep endometriosis. Operating out at Bordeaux, France, as well as Abu Dhabi and Denmark, he has dedicated his career in advancing the care of patients with challenging endometriosis cases involving digestive tract, urinary systems, nervous system, and also the extraperitoneal sites. With over 230 scientific publications in his name, having treated more than 5,000 patients, including some of the most intricate and complicated cases, his contribution to the field are nothing short of revolutionary. He has performed over 500 rectal disc excision, developed techniques to preserve ovarian functions, and pioneering in conservative surgery that continues to shape treatment standards even today. Beyond his surgical accomplishment, Professor is leadership in research is equally remarkable. He has led groundbreaking trials like Endure, Measure, Effort, which have had a profound impact on both surgical and medical achievements in endometriosis and infertility treatment. With over 130 lectures across 6 continents and 70 live surgery broadcasts worldwide, his influence reaches far and wide. Today, we are honored to have him with us to share his unparalleled insight, invaluable experience, and inspiring journey. Professor Roman's work continues to set new benchmarks in both clinical practice and research work, inspiring clinicians and researchers around the world. We are truly privileged to have him here today. So let us dive into this enriching conversation with none other than Dr. Professor Horace Roman on the topic Deep Dive Infiltrative Endometriosis, Master's Part to Mastery. As DIE accounts not less than 10% of women of reproductive age and approximately 190 million girls and women, they suffer from this painful condition. So we welcome you, sir. Thank you so much for spending your time with us.
Thank you very much for this introduction. I'm very honored to be with you this morning.
Thank you, sir. So, sir, we should love to start this conversation with, could you please share with us a few pivotal moments you have in your career that shaped your expertise in this advanced endometriosis surgery?
Yes, you have to know that I decided to become surgeon when I was 10 years old.
Oh.
And then everything I have done was destined to this career. But until the age of 31, nothing was destined me to become OBGYN. So I stepped the first time in the operative theater when I was 20 years old, so first year of University of Medicine. But from age of 20 until 27, I was involved only in colorectal procedures. So I was destined to become a colorectal surgeon. And then when I was 27 years old, I completely changed the field. And I attended, I had a residentship in neurosurgery, so I decided to become neurosurgeon. And by chance, when I was 31 years old, I decided to change to OBGYN because I met a wonderful professor and the head of department in the University of Rouen. I decided to become OBGYN at age of 31. And I discovered the endometriosis when I was resident in the 5th year. So it was in 2002 when I spent 6 months in the department of Clermont-Ferrand in the middle of France under the leadership of Michel Canis and Arnaud Vattiez. So at that time, when I was 35 years old, I discovered the endometriosis, the disease which will become my main topic of research and surgery. So I became an endometriosis surgeon very late when compared to my young colleagues who come in fellowship and who are 30 years old, so they know they will become endometriosis surgeons. So my major moment of my life, which helped me to become what I am now, were for sure the visit 1 year spent in Clermont-Ferrand, where I discovered endometriosis. In 2003, my PhD, my master and PhD in epidemiology, which gave me the view on the epidemiological and how the epidemiology can deserve the clinical medical research. So all my researches on endometriosis are based on the training I received during this PhD in epidemiology. And then in 2011, I decided to focus exclusively on deep endometriosis. So I stopped seeing patients coming with other diseases. This helped me to develop a very
focus
experience, yes. And the last very important step is when I moved from the university, from the public system to the private system, and with my colleague Benjamin Merlot, we built the Franco-European Institute of Endometriosis in Bordeaux, with more than 1,000 endometriosis surgery a year and more than 300 very complex surgeries a year. So these were my main steps, which helped me to become what I know.
So as is correctly said, nothing that you learn go waste. So your background of having a colorectal concepts and that all, make, so there is no age limit to learn anything new. That's a
Exactly.
very,
So the 7 years spent in the colorectal department helped me to develop the surgery of colorectal endometriosis, and the 4 years spent in the neurosurgery department at Pitié-Salpêtrière in Paris helped me to approach the nerves.
wonderful, sir. So it's your remarkable journey, and as you have, it's a perfect blend of having the, one could have in their career. So it's never late to start anything new.
Never late to start if you put all the means on the same project. And my director of PhD in epidemiology told me in 2003, Horace, you have to dig in only one place in order to dig into the depth.
Thank you. It was really wonderful to listen all that. Sir, I would like to lead the questions like over the years, what significant changes or advancement in the surgical technique of DIE have you embraced? And have they have any impact on surgical outcome, whether it is evolving or whether how it is impacting the outcome?
Yes. So I can count 20 full year of surgery dedicated to endometriosis. However, my procedures have not been the same during all this period. So several times I came to realize that we can do better because the surgery has some impact on our patient. For example, in 2009, I came to realize, I understood what the low rectal resection syndrome means, the LARS. So the LARS was at that time a new concept showing that the surgery of colorectal endometriosis to remove a disease such as cancer or endometriosis may lead to functional troubles which may worsen the quality of life of patients even though they do not longer have the disease. And this LARS, I understood at that time that it can be done to the shape of the rectum, operated rectum, and to the denervation of the rectum. That's why at that moment I started trying to replace the colorectal resection by disc excision, and I extended the indications for shaving. And at that moment I wrote the protocol of the endo-randomized trial, which is the unique trial which compare in the randomized manner the conservative surgery by shaving or disc excision to the colorectal resection. So this is maybe my most important clinical study I have done until now, endo-randomized trial. And so the disc excision, I have performed more than 500 disc excisions, but I started at that moment when I tried to replace the colorectal resection by another technique with a complete excision of the nodule, but with the conservation of the rectum. Then in 2008, 2009, there was more and more information about the risk of ovarian failure after the surgery of endometriomas. You have to know that before 2009, 2008, the endometriomas were managed by cystectomy, and the cystectomy was done in young women, in bilateral endometrioma, no problem. And we realized that many of these patients come back with ovarian failure and the impossibility to start a pregnancy. So at this moment, I completely replaced the cystectomy by a vaporization using plasma, and I carried out several studies in order to assess the ovarian reserve. So this is another point where I completely changed my manner of surgical approach. Then in 2011, I started robotic surgery and progressively understood that the robotic surgery is the excellent indication for diaphragmatic endometriosis, for the parametrial endometriosis, for the sciatic nerve endometriosis, so with improvement of outcomes.
So, while you have directly witnessed and you have tried by yourself improving all these surgical steps towards the patient's benefit.
Each time I saw that the surgery may not provide the results I was expecting, I try to understand why it does not happen, why the patient are not improved, and how I can do better.
Wonderful, sir. Your studies are really, everyone quotes that study in their, as a reference, and we take it as a standard for this all outcome of the patients, sir. So, sir,
almost all the studies are based on a question that patients or colleagues ask me. So each study tries to answer a question.
So my question is directly related to this. Next is, how does this extensive laparoscopic surgery on endometriosis can improve the quality of life of patient? If you have any particular story of particular patients, please kindly share with us.
Oh, so as I told you, I carried out a lot of very complex surgery, and every week, I count that every week I have at least one patient with very severe or subocclusive endometriosis or sacral plexus. So each story is very, very, very typical and very critical. And I was discussing with my colleague that every week we perform surgeries which may be the surgery of the year in over departments. So it's very difficult to choose a story because I have a lot of patients with complications for sure. So if the fistula represents 2% of patients, it means that I had not far from 60 or 70 cases with fistula with very difficult management. And one of them I remember all the days of the management. One of them happened in 2008, and I remember that the patient was the first very severe complication I had, and the patient spent 2 months in the hospital and lost 10 kilos. So it was the fistula after shaving. So I understood at that moment that the shaving, if it is too deep, too adventurous, may lead to unbelievable complications. And I continue to have the contact with these patients 15 years after, and she has become mother, so we have a very good relationship. And very interesting is that of the well-known French actress, 10 years of infertility. So she wrote books and she made a movie. She was speaking about endometriosis and infertility in all the newspapers. And she ultimately come to me with 3 colorectal nodules. And I performed the surgery, and she became pregnant naturally without having periods. So it was and I told her, your history proved much more, has done much more for the knowledge of information of people than all my previous articles in human reproduction. The article about her was published in Gala, and I said, this publication is much more read than all my past articles.
Wonderful, sir. Continuing with our conversation, that such a inspiring and motivating patients' reviews and their feedbacks, and it is immensely satisfying and probably cannot compare with an amount of the momentary benefits what we gain from this profession. I would also like to know this. Very young surgeons are they are aspiring to excel their fields. This is very challenging. Even in laparoscopy, many find challenging. Apart from that, being an endometriotic surgeon is really a challenging field. What the key skill or training or mindset would you recommend those as a master? You recommend those very aspiring new surgeons?
Well, from the onset, I wish to emphasize that I believe that it is much easier to become a very good endometriosis surgeon now in 2025 that in 2005 when I started this surgery. Why? Because at that moment there were no videos available about the surgery. So to see how the surgery happens, I had to go to congresses, to go to Clermont-Ferrand, to look for VHAs with surgeries. So it was very difficult to increase my experience. While now our colleagues have a lot of videos available on YouTube or various sites. Me, I have a YouTube channel with 1,000 surgeries, and most of them with comments or full-time surgeries. I broadcasted in live surgeries or just recorded in my operative theater. So it is very easy now to understand how the surgery is done, which are the steps of safety, of security, how the dissection should be done. There are a lot of video articles in many reviews. So I think the young colleagues need time to review all these videos and a strong motivation, the willing to be better and to become surgeon. Then another very, very important point is to spend fellowships in immersion in various departments. And I am proud to say that since 2018, we have received 350 surgeons. And I think from India, we have received not less than 80 or 90 surgeons, and well-known surgeons such as Abhishek Manjeshikar or Deka or Hemant accomplished the training here in Bordeaux and have become very good friends. That's why I'm very sensitive to any invitation I have from India for broadcast, because Indian colleagues are actually friends. And which is very important once you had a fellowship, to keep the contact with the mentor and to discuss cases or MRIs, or to have a feedback and a review. And what I tell to all my colleagues, young colleagues, when you start the surgery and when you see the patient, think that this young woman could be your wife, or if you're older, it could be your daughter. And honestly, I have 3 daughters, and 2 of them have health issues, and I'm disappointed to see that I have never received the care for them, the care which I provide to my patients. And this is disappointing for me. So it is very important to manage many patients, but it is more important to manage them well and the patient to be satisfied.
So important message you have conveyed, sir. Spark, passion, give time for training, perseverance, and be honest to your patient. Wonderful, yeah, sir. That's what else one can expect from a mentor like you, sir. Sir, looking ahead, say in future, what innovations or a shift in the management of this deep infiltrative endometriosis do you foresee? And how do you see the role of this surgery evolved with this space?
Well, if I look back during the last, let's say, 30 years, I think there were 3 revolutions which could greatly improve the development of endometriosis surgery. The first was the laparoscopy. Performing the laparoscopy helps us to understand the disease. The second was the MRI. MRI was the first exam which provided us a 3D view on the deep endometriosis nodule we removed. And the third, I think it is the robotic surgery, which helps us with the mobility of the instruments, which help us to work in a very, very few volumes in the depth. Now, if you look ahead, I think we need to benefit from at least three improvement. The first one is most likely the augmented reality. We need to introduce the augmented reality in deep endometriosis surgery in order to see the limits of the nodule, to superpose the view from MRI on our operative field to understand where are the limits of the nodule. This has already been done for myomas or for spheric tumor into the kidney or the liver. It is much more difficult to do it for endometriosis nodules, which are very anfractuous and which limits are very, very difficult to understand. But it should be done. I'm sure it will be done. The second is using markers, some markers like the fluorescein, but some markers which are specific for the nerves in order to avoid to denervate the organs. So if you can inject something into the vein of the patient and then see in green or in brown the nerves, the small nerves, the inferior hypogastric plexus, this would be a great advancement. And in this way, we can avoid a lot of cases of denervation of the bladder, of the rectum, of the vagina. And maybe a third improvement could be done to a kind of autonomic robots, surgical robots. I think like the Tesla or other autonomic cars, they can be autonomic safely in a very short perimeter. So let's see, to start the surgery by letting the robot dissecting the ureters, dissecting moving the sigmoid, so preparing the surgery, because then when we approach the nodule, I think the autonomic surgery is very difficult to implement. So I think that the surgeon will still be the mandatory actor, the mandatory director of the surgery, but I think that autonomic surgery may carry out some steps at the onset of the surgery with more safer than a surgeon can do.
So with the AI and robotics, we'll have everywhere Professor Horace Roman's skills and techniques available for each patient. That would be wonderful. Sir, thank you so much for your time, and it is very interesting to know this part of your life, then also the surgical skills and videos we keep on watching every time. If time permits, would like to have some rapid fire round to make it more interesting for our viewers. So shall I start some questions, sir?
Yes, of course.
So, sir, one mentor or figure who inspire you the most in your journey? Only one name.
One man who inspired me, I think it is the first teacher of surgery I had, is a wonderful surgeon, amazing surgeon in a small city in Romania, in the middle of nowhere. His name is Dr. Vaida.
Wow. So we are so grateful to the Dr. Vaida for creating such a legendary surgeon in front of me today. Sir, the most challenging case you have ever managed in endometriosis surgery?
Wow, it's difficult. It's very, very difficult. I will take, let's take the last one I had, and which happens in September because it's the most recent. A patient with coming from England with past open surgery, bowel resection, and section of the ureter, and the surgeon left behind a huge nodule which secondary infiltrated the rectum, which was resected, the sciatic nerve, the sacral plexus, and the over ureter. So the surgery took 10 hours.
Oh, wonderful, sir. It's a great passion you need to do manage such a
10
case.
hours, 10 hours when we take into account then that to perform a colorectal resection with the robot, I need 1 hour and a half.
Oh.
So I
So
spend
it's
eightfold more time
more,
than perform a simple colorectal resection with the robot.
yeah, 8 times more complex.
Yes.
Sir, is there any go-to tool or technique you have for DIE cases?
Sorry?
Is there any go-to tool or technique, any particular that you just go with it for DIE in all cases? Or you modified it as case per case?
I modify. I think that the surgery of endometriosis is a custom-made management. So for each localization, I think it's very important that the surgeon masters at least 2 or 3 techniques and to use each one depending on for example, in endometriosis, I carry out disc excision, segmental resection by nose and shaving. So I employ it depending on patient's features. For ovarian endometriomas, we use cystectomy, vaporization, sclerotherapy, or simply drainage.
Sir, your preferred approach for DIE surgery, laparoscopic or robotics?
Now I think I prefer robotic. For my most complex cases now or robotic.
Sir, one book or any resource that every endometriotic surgeon must read.
Wow, because books, there are a lot of books. I think the problem of the book is that from the moment where you read the chapter and to the moment where the book is printed and sold, it takes 2 years. So usually I prefer to read articles than books. But there are a lot of books. One of the last one is written by, coordinated by Prashant Manjeshikar. So there are a lot of books in very good books in endometriosis. I cannot nominate one.
Okay, I can understand.
About others.
Okay, sir, I understand completely.
But if for the surgeons who try to understand the colorectal management, I think a very important paper is one of mine, for the papers dedicated to the endo randomized trial. So there are 5 papers with the follow-up. The last one, 10 years follow-up of patients enrolled in endo randomized trial is ongoing. The review is ongoing in human reproduction. So these articles try to precise everything about the colorectal endometriosis surgery.
Okay, sir. So next is our one surgical skill one must have before going ahead to the endometriosis surgery. Extensive endometriosis surgery, I mean.
I think that the most important skill is to know to see very, very well the anatomy. It is unbelievable how many surgeons, and I have also fellows, come to learn the deep endometriosis surgery, and they do not recognize which is the hypogastric nerve, where is the parametrium, where are the splanchnic nerves, where is the low rectum. So somehow I'm negatively amazed by this. You start by understanding very, very well the anatomy, then the modified anatomy, and then to go to the surgery.
Absolutely correct, sir. And the most underrated skill in endometriosis surgery, what it would be?
Most
underrated skills in endometriosis surgery. You did the most difficult part and still it is not given appropriate credit to that.
I think the most difficult part of the endometriosis surgery is the deep parametrium. So the deep parametrium, where we have to to try to preserve as much you can the inferior hypogastric nerve, inferior hypogastric plexus, where the nerves are very small like the hairs. And also you have to manage with large vessels from the internal iliac network, veins and arteries, and to preserve the sacral roots. I think is the most difficult part of the surgery.
Yeah. And sir, any biggest misconception about the endometriosis surgery? I'm talking in perspective of surgeons, like surgeons like me may have the biggest misconception. That is it that too difficult? It is very morbid, or is it not rewarding? It is like medical management is better.
I think one of the huge misconception in surgery is that the surgery can do anything. And I frequently see on internet surgeons saying, yeah, the surgery may cure endometriosis. So I don't think that the surgery may cure endometriosis, because we do not know where the cells come from, and we always, even though we do a perfect surgery, we may have recurrences, because I always tell to patients, the surgery may you come back to the age of 15 with very small lesions or with no lesions, but if you have periods, you can recur, because you do not know where. So I think that then the big misconception, a big error, is to be too confident in the surgery. So even you perform a perfect surgery, it does not cure endometriosis. And I think that some surgeons either believe or make patients believing this, and I think it's not a right path.
That is so honest answer coming from the epic surgeon of endometriosis. I bow to you, sir. Wonderful. Sir, what is your habit or your mantra or your practice that keeps you at the top of your game?
So which is my practice, which is the top of my aim?
Yeah, why you are maintaining your being a topmost endoscopic surgeon? What is your habit, anything, or any your secret recipe of being?
But the secret to stay in the top is to be aware that there are a lot of surgeons coming to see you and who want to do better with you, better than you. And if you do not doubt about what are you doing, it means that you have already been you have already has been surgeon. So you have continuously to improve and to be aware that all the guys you train may be better than you and will be better than you in the future. So it is very important that this future to be the most far possible, the farthest possible.
Exactly. The day we think we know everything, that is coming back from your position. Yeah.
I have to doubt and try to understand how to can improve. And you have to run fast, to stay faster and faster, to stay in the top.
Sir, which country or the institution you see as leading the way in endometriosis research? So where we should look ahead for?
I think in surgery, in the surgical field, I think that in Europe the most center over mine is that of Marcello Ceccaroni. There are 8 surgeons. They have a volume of surgery which is over our surgical volume, and they perform a wonderful surgery, a lot of training, and so I think it is the wonderful department, the best. Me, I say it is the best maybe in the world. As regards the scientific, the basic science research, there are so many centers in United States, in England, in France, in Australia. So I cannot rank them. I can rank the surgery because we have the volume of surgery, which is a marker. But in terms of basic research, I cannot mention one of them.
So, sir, we are so amazed you listening your honest opinions. Sir, would you like to have coffee, or would you like to have, are you a coffee person or a tea person before surgery?
I'm a coffee person.
Coffee person. So
And even
one
now,
technical, exactly, I saw that and thought, wondering me what you are having in your cup. The one technological advancement you wish existed in endometriosis surgeries.
an advance which I wish to.
It should existed.
I think it is this what I told you about the augmented reality. Augmented reality coordinated with markers which which indicates the small nerves. I think it is an innovation we should have as soon as possible.
Sir, anything in your entire journey you would wish to change, or if you like give to a piece of advice you would like to give to your young self, what it would be?
But I think if I could change, if I could change something in my career, would have been to start earlier this journey. Because as I told you, I started the endometriosis. I dedicated myself 100% to the endometriosis surgery at the age of 44. So I think I could have been done it 10 years earlier. And in this case, I could have a longer journey.
And more hundreds of patients could get the benefit of having operated under you. Yes.
Yes.
So wonderful, sir. Sir, thank you so much. This was really very interesting interview, and I never thought I would also enjoy so much knowing you so personally, and entire your journey is really inspiration. Just one piece of advice to young surgeons would love to, as you are being mentor or for many like us.
So my advice is find the time to attend a fellowship in a very, very good department, and this could change your life.
Thank you. Thank you so much, and shukriya, sir, for being with us.
Thank you very much.
I'm really thankful to Fogsi Initiative and Dr. Sunita Tandulwadkar Madam for we are really enjoying this interview, and I am very sure these viewers would love to watch it again and again. And soon to see you, sir, in person. We're definitely going to book my slot for next term. Thank you,
Thank you
sir.
very much. It was a privilege to discuss with you.
Thank you, and thank you this team for arranging all this podcast very smoothly and without any flaws. Thank you.
Thank you. Have an excellent day. Bye.
Thank